Okay, we do want to be respectful of the schedule that we have today. We have a lot of ground to cover. Thank you so much for joining us this Saturday morning and for dialing in. We're going to begin the conference today with a lecture from Dr. James MacKillop, who, as you can see from the title slide here, has a number of roles at McMaster University. He is the director of the Peter Boris Center for Addiction Research. He is a professor in the Department of Psychiatry and Behavioral Neurosciences. And of course, he's the director of the Michael G. DeGroote Center for Medicinal Cannabis Research. And he's going to be complementing the last talk we had for yesterday's session, which was about potential benefits of medicinal cannabis. And this talk is going to focus on the other side of that, which is the potential harms associated with use of cannabis. And we'll begin.
Wonderful. Thank you, Jason. Good morning, everybody. It's great to be with you. As Jason alluded to, my job today is to basically speak to the other side of the coin. We are interested in characterizing the medical benefits of cannabis, potentially, across conditions, and those have to be weighed against potential harms. I've shown these before. These are the same disclosures. I do get unrestricted research funding, and I do have some commercial interest, but no relationships to any commercial cannabis companies. And our center is funded entirely in its core operations by philanthropy. I also want to start with an overview of the many different facets of understanding potential risks and harms from cannabis. And we're going to start in the brain and focus on cannabis use disorder, the psychiatric diagnosis for problematic cannabis use or addiction. We're then going to look at its overlap with other mental health conditions and also how cannabis affects cognitive performance. We're then going to move away from the brain, look at cannabis and lung health, as the most common route of administration remains inhalation. We're going to move to the GI system and talk a little bit about cannabis hyperemesis syndrome, or CHS, which once was a very rare condition and has only been identified in less than the last 2 decades, and now is increasingly common. And then the last section before conclusions will be thinking about these risks and harms specifically in the context of medical cannabis use and how people who use cannabis for medical purposes do so. And then I'll conclude with some final thoughts. So lots to cover today. I do want to acknowledge some folks and add some considerations. I will be presenting some of the data that's come from my lab, that's come from collaborators and former trainees. In particular, some of the empirical findings I'll report were led by Max Owens, Jasmine Turna, Tashia Pecker, and Melissa Parlar. In general, much of the work I'll review will be focusing on the forest rather than the trees, looking for systematic reviews and meta-analyses that can give us insights into the overall evidence base, but I will use individual studies to highlight points and illuminate some of the nuances. So let's start with cannabis use disorder. Well, to start with, many people, unfortunately, still tend to think that cannabis use disorder is a somehow lesser or non-existent psychiatric condition, that the idea of becoming addicted to cannabis is a myth. That's not true. Cannabis use disorder is akin to alcohol use disorder, tobacco use disorder, opioid use disorder. It is a diagnosable condition. The way to think about the various categories of severity and the notion of cannabis addiction more generally can be illustrated in this figure, in which we can show sort of a Russian nesting doll of different risk categories. So when it comes to all substance use, not just cannabis use, substance use can be thought of as being defined as a level of use that is associated with risk of adverse consequences. That's risky substance use, risky drinking, risky cannabis use. Then within individuals who might be at that level of statistical risk, substance use disorder is the clinical diagnosis, according to the Diagnostic and Statistical Manual, most widely used in North America. for giving psychiatric diagnoses. Substance use disorder is the diagnosis for an individual experiencing clinically significant distress or harm from the substance. In this case, cannabis use disorder. Substance use disorder is a syndrome that comprises up to 11 symptoms, and 2 or more symptoms are needed to make the diagnosis. When we talk about cannabis addiction, what we tend to be referring to is a subgroup within substance use disorder. Addiction is a colloquial description. It's not a clinical description. A doctor can't diagnose a person as being addicted to a substance. Typically, this refers to people who have moderate to severe substance use disorder, which is typically defined as 4 or more symptoms of substance use disorder. So to dive more deeply into what cannabis use disorder looks like, these are the 11 symptoms, and we'll go through them because they kind of cluster together. The first 3 are that cannabis is used in larger amounts or over a longer period of time than intended. Basically, there's a loss of self-regulatory capacity. A great deal of time is spent obtaining, using, or recovering from cannabis use. People want to, but are unsuccessful in attempts to cut down or reduce their cannabis use, and they experience persistent and/or intense cravings for cannabis. These can basically be thought of as the symptoms that capture a person's inability to regulate their consumption or loss of control of consumption over the drug. Then there are a number of symptoms that reflect the consequences of use. So continuing to use cannabis despite knowledge of problems, either physical or psychological, the cannabis use resulting in major role impairments, leading to social or interpersonal problems, or leading to a person giving up the other meaningful activities in their life. And then finally, cannabis use in situations where it's physically hazardous. This obviously could be, for example, operating a motor vehicle, but could be also, for example, when swimming or in occupational settings where there could be risk of harm if a person is impaired. These all fall into the kind of broad category of cannabis consumption despite negative consequences. And then the last 2 symptoms are tolerance and withdrawal. Tolerance being the need for more of the drug, in this case cannabis, to feel the desired psychoactive effects, or the same amount of the drug no longer producing the amount of psychoactive effects. And then withdrawal being a discontinuation syndrome after a person stops using cannabis, or a person reporting that they need to use cannabis or do so in order to keep withdrawal symptoms at bay. So these are basically the symptoms that reflect physiological dependence. These symptoms, if you look at them together, form a highly internally consistent syndrome. They are unidimensional, like the other substance use disorder syndromes. And although they do not all scale equivalently, these 3 different distinctions are really less important than reflecting the fact that these all are parts of what the disorder looks like. In terms of cannabis withdrawal more specifically, another myth has been that you cannot become physically dependent on cannabis. This has been very robustly disproven via extensive empirical research. Certainly tolerance has been widely documented, but also the cannabis withdrawal syndrome has been documented now in great detail and seems to be very reliably predicted by heavy use followed by discontinuation. It's diagnosed based on there being 3 or more of the following symptoms: negative affect, i.e. irritability, anger, or aggression, also nervousness or anxiety, difficulties with sleeping, disruption in appetite, agitation or restlessness, depressed mood, and then physical symptoms that are uncomfortable also, things like abdominal pain, tremors, sweating, fever, chills, or headache. So certainly there was a time when people thought that one could not develop physiological dependence on cannabis, but that has long been disproven. So how does cannabis use disorder come about? Well, we could have an entire lecture and, to be honest, an entire conference on the biopsychosocial determinants of cannabis use disorder. But at a very narrow level, we think of it as having a at least partially biological basis based on how the brain changes in response to persistent exposure to cannabis and the associated cannabinoids, specifically THC. So this is a PET image of CB1 receptor density in the brain. Those of you who attended the first foundation session may recognize it. This is where anandamide and 2-AG bind to CB1 receptors as part of the endocannabinoid lipid signaling system. And it's also where THC and other phytocannabinoids bind. And what we know is that these receptors are preferentially expressed in regions of the frontal lobes, regions of the occipital lobe, subcortical regions like the basal ganglia, and also critical regions for memory and emotion, the hippocampus and the amygdala. CB1 receptor is also localized outside the central nervous system, and so cannabis does have effects peripherally also. But when it comes to cannabis use disorder, we believe that the major neurobiological basis is in the central nervous system. So what happens if you use cannabis at high levels persistently? Well, the brain changes and adapts to that overstimulation of the endocannabinoid system and downregulates the number of CB1 receptors. These are data from another PET study showing individuals with cannabis use disorder relative to healthy control participants, and showing the different regions of the brain where there are significantly fewer CB1 receptors in the individuals with cannabis use disorder. So that is particularly in regions like the prefrontal cortex, the parahippocampal gyrus, the parietal lobe, the insula, and the anterior cingulate. These are critical regions in the brain's key networks like the central executive network, the default mode network, and the salience network. And what we basically see is that the brain changes in response to persistent exposure to THC and downregulates CB1 receptors, and that's responsible for aspects of tolerance insofar as the same amount of the drug no longer has the same impact. And also, after the drug is discontinued, the downregulated levels of CB1 receptors are the basis for those withdrawal symptoms and also for cravings. This just brings these results into sort of sharper relief. These are the differences from the previous figure. So again, I want to emphasize that we see that there are significant reductions in anterior cingulate, amygdala, parahippocampal gyrus, prefrontal cortex, insula, critical regions for cognitive functioning in a variety of different areas, all of which are downregulated or have downregulated levels of CB1 receptors over the course of development of cannabis use disorder. What's really interesting is that this does change over time. So here's another study, also a PET study, that highlights the differences to start with. And I'll show you data in a second showing how this changes over the course of abstinence. Like the previous study, you can see that if you just compare individuals with cannabis dependence to healthy controls, there are significantly fewer CB1 receptors in brain as a result of neuroadaptations. It's really brought into sharp relief here. If you look at the whole brain results, with the red being where there's the highest density of CB1 receptors. And then this is the individual regional differences, again, highlighting amygdala, insula, and areas like the hippocampus. But what's interesting is if you look over time, these are the cannabis use disorder individuals at baseline, and then 2 days later, and then at 28 days later, there is a gradual restoration of CB1 receptors. There is a gradual increase. These significant differences at baseline become non-significant over time. And you can see this slight gradient, a trend towards basically increase in CB1 receptor density 28 days later after a monitored period of abstinence. Now, the CB1 receptor is not back to the level of healthy controls at that point. And of course, these are largely cross-sectional, or at least in this case, longitudinal studies that are over pretty short windows of time and can't tell us about overall trait levels. But basically, we start to see that the brain is exhibiting recovery of function in terms of CB1 receptors over the course of abstinence. So this is a kind of narrow conceptualization of the development of cannabis use disorder. There are many other psychological, psychosocial, and sociocultural factors. But from a narrow pharmacological standpoint, this is the basis for cannabis use disorder. If we think about the actual rates of cannabis use disorder, this is another figure that may be familiar from the initial foundation section. The overall population rates are relatively high in Canada and in the United States compared to comparator nations. About 1 in 6 individuals report any use in the last year. In terms of cannabis use disorder, the Canadian lifetime prevalence is about 7%, and the 12-month prevalence is a bit over 1%. So not very common, but also not non-existent or at trivial levels. In terms of the United States, the prevalence for cannabis use disorder over the lifespan is similar, about 6%, and the 12-month prevalence is estimated to be between 1.5% and 3%, a bit higher than Canada. And also the overall rate of use in the US is a bit higher also. Let's try to put this in context though. So one way to think about how addictive cannabis is to think about the risk in the context among people who are actively using. So these are data from a large epidemiological study, and it's a really nice analysis looking at the percent of people who meet criteria for dependence, what was then the definition of a substance use disorder, among the people who were using. So not in the general population, but among people using a drug, how many would meet the clinical definition. And here what we see for cannabis is it's about 8%. So considerably lower than cocaine or opioids in this study, considerably lower even than tobacco, which actually has the highest rate of meeting the clinical definition among active users, similar to alcohol. Less than 1 in 10 individuals. So a very clear minority of active users meet criteria for a cannabis use disorder, but again, not a trivial number either. That number is very far away from 0. The other way to look at this is among people who've ever used the drug, what percentage progress to developing a lifetime substance use disorder. So let's set aside people who've never used a drug, how likely it is for you to progress if you have ever used it. And in this case, what we see, cannabis actually has the lowest rate. So about 9% of people who, again, this large epidemiological survey, about 9% of people who had ever used cannabis at one point then developed a cannabis use disorder. That's lower than alcohol, lower than cocaine, much lower than tobacco, which again actually has the highest rate. Over about 2/3 of people who had ever used tobacco at some point met criteria for tobacco use disorder. All right, so let's talk about moving away from cannabis use disorder, the diagnosis. Now let's talk about how cannabis is associated with other psychiatric disorders. And this is really important because with pain and sleep, mental health concerns are the most common reasons that people report using medical cannabis. So understanding this relationship is really critical. Let's start with what the epidemiological data can tell us. And here it is pretty robust at a cross-sectional level. And basically cannabis use disorder, and indeed cannabis use, is statistically associated with virtually all other psychiatric disorders. And I'll give you a rundown of what this looks like using 2 very large population representative studies conducted in the US. These are called the NESARC studies, the National Epidemiological Survey of Alcohol and Related Conditions. And the original NESARC study had more than 43,000 participants. A follow-up NESARC 3 had more than 31,000 participants. And what this shows in summary from these 2 major surveys separated in time are the adjusted odds ratios of cannabis use disorder with other psychiatric diagnoses. There's obviously a lot of data here. We'll walk through it bit by bit. The adjusted odds ratios basically tell you the probability that a person with cannabis use disorder will also have the other associated condition, adjusting for demographic covariates. And what you can see here are the different conditions. The measurement was slightly different between the two surveys, which is why there are some gaps, but they have some very consistent findings. So if we start with any other substance use disorder, this is where the highest overlap is. So we see that there are robust associations with alcohol use disorder, with nicotine use disorder, with any drug use disorder. The odds ratios are consistently over 6 times more likely, and as high as 9.3. So cannabis use disorder very much aggregates with other substance use disorders. If we look at any mood disorder, we also see robust associations. The odds ratios are somewhat lower, 2.9 and 3.8, but still basically around 3 or higher times more likely to have a comorbid mood disorder. If we move to any anxiety disorder, you can see it's pretty similar to mood disorders, a little lower, but about 2.5 times more likely to have an anxiety disorder. What's most notable to me is the highest of these is for panic disorder in one case and for post-traumatic disorder in another case, 2 conditions we definitely hear a lot about clinically. And then last, if we look at the personality disorders, here the associations are actually even higher than mood and anxiety disorders, between 3.9 and 4.8 when it comes to the adjusted odds ratios. So basically 4 to 5 times more likely to have a comorbid personality disorder. The other health behavior that is not a psychiatric disorder per se, but is very clinically relevant is self-injurious behavior. And these are data from a recent systematic review and meta-analysis. What we see is that cannabis use is quite robustly associated with self-injurious behavior. The odds ratio is about 1.5, so about a 57% increase in likelihood of reporting self-injurious behavior. That's in cross-sectional studies. It's actually higher in longitudinal studies, about 2.57, so substantially higher, which obviously is quite troubling. Many of you may be familiar that there's a link between cannabis and psychosis. Psychosis is typically not measured in many of the big epidemiological surveys because the population rates tend to be very low in the general population. But there nonetheless has been a great deal of investigation of the association between cannabis use and psychosis. These are data from a recent systematic review and meta-analysis that estimates across studies the relative risk for developing psychosis based on adolescent cannabis use is 1.71, so a 70% increase in risk by virtue of using cannabis during adolescence. This has been converted in a creative other study to estimate how much of the first episode psychosis might be attributable to cannabis use. And in that study, looking at 5 European countries, they estimated that about 12% of the first episode psychotic, the first episode psychosis episodes, that doesn't sound quite right, but was essentially 12%. And so this is not a trivial association by any means. What's interesting is we're getting closer to understanding at least the nature of the association. There are very clear dose-response relationships. Consumption of higher amounts, which is probably not surprising, but in particular, high THC products increase the association and the risk for developing psychosis or psychotic symptoms. And a recent systematic review and meta-analysis looked specifically at trying to parse a dose-response relationship with frequency. And what they found was that if you look at yearly cannabis use or monthly cannabis use, there's no statistically significant increase in risk for developing psychosis. But weekly, and in particular daily use, is significantly associated with developing psychosis. So it really appears to be relatively frequent, and in particular daily cannabis use that has this association, along with the use of high THC products. We don't understand the causality here, and I think that that's important to note. A lot of these relationships are either cross-sectional or over time, they are observational. You can't easily randomly assign people to use cannabis or not. And I think that what we know is that, unfortunately, cannabis and psychosis and cannabis and other mental health conditions are frequently fellow travelers. The longitudinal studies typically show that use of cannabis forecasts greater severity over time, although in many cases, it's not clear what the causal nature of the relationship is, and that's still very much an area of inquiry. What about cannabis and cognition? This is a obviously similar area to mental health, but it refers more to the general cognitive faculties of the brain. And again, why are we interested in this? Well, because the endocannabinoid system is critical for cognition. The CB1 receptor is the most abundant G-coupled receptor in the brain. It is implicated in a wide variety of normal, healthy cognitive functions. And so we would imagine that cannabis would be likely to have potential impacts on cognition. The other reason is that cannabis effects on cognition are important for all cannabis users. It doesn't just matter for people who have cannabis use disorder. It pertains to recreational users also. And it's particularly pertinent to medical cannabis patients because it could be a significant side effect. Some of the benefits, for example, for pain or for sleep or for another condition may be outweighed if a person is experiencing significant cognitive difficulties, especially if the individual was either vulnerable or, for example, had another condition, for example, in seniors, something like MCI or mild cognitive impairment. The other reason that we as a center are very interested in cannabis and cognition is because the existing evidence is quite inconsistent. And it's very easy to say, cannabis is deleterious for cognitive functioning, but the actual nature of that relationship is much more nuanced than I think is often appreciated. So to give you an overview of what we know about cannabis and cognition, I'm going to use a systematic review that was done a number of years ago that did a nice job of synthesizing the overall evidence base. And this was a systematic review that integrated, first combed through thousands of articles and ultimately winnowed down the literature to 105 cannabis and cognition studies. And what they found were a variety of different effects of cannabis. And there's a lot going on in this slide, but we'll walk through it piece by piece. On the left-hand column, you can see the different domains of cognitive function. And then you can see the different levels of involvement of cannabis, acute, chronic use, chronic use, whether or not the effects persist with abstinence, and other moderating factors. And to start with, what we know is that there's quite good evidence for acute effects in a number of areas. Where you see plus signs, that's basically the strength of the evidence. And so you can see that there's robust evidence that acute use of cannabis affects verbal learning and memory, attention, psychomotor function, things like reaction time, behavioral inhibition, the ability to inhibit an arising response. These are all some of the reasons that cannabis is considered risky when it comes to operating a motor vehicle or in safety-sensitive occupational settings, because fundamentally there's a lot of acute impairment, both with higher order functioning and also some of those more basic psychomotor and inhibitory control functions. That's relatively consistent. If we look at chronic use, we see somewhat similar relationships. We see robust evidence that cannabis is involved in decrements in verbal learning and memory, attention, attentional bias, and modest evidence for psychomotor function. And this refers to people who are ongoing regular cannabis users, not whether or not they've stopped or not. That's the next category. And here we see that if you look at which effects persist after a person stops using cannabis regularly, the literature gets very inconsistent. Lots of pluses and minuses, lots of not applicable. And fundamentally, there's not a lot of consistency on the extent to which cannabis effects on cognition persist beyond either acute intoxication or regular use. The other factor here is, of course, that there are lots of other things that seem to influence these relationships. How frequently you use, your total lifetime use. One of the big questions has been, what if you start earlier in life? Does earlier age of onset lead to decrements in cognitive performance later in life? And so there are a lot of other factors to consider. We've been investigating these questions locally, and really to summarize, we've been trying to address what the limitations are of the existing literature. So unfortunately, there's a lot of inconsistency, in part because there are different tasks being used, different methodologies. There are many small studies that may lead to publication bias. The reality is neuropsychological or neurocognitive testing studies typically have relatively small sample sizes because they require quite intensive testing of participants. And as a result, small studies may have interesting statistically significant findings and be published, but may not be robust. And obviously, small studies that do not have significant findings are less likely to be published. That's one of the natures of publication bias. There may, of course, be just general measurement error because of different batteries that are being used and different methodologies. And then the other more cryptic bias-inducing factor of small studies is that they can't adjust for pertinent confounders. If you only have a small sample size, with every additional covariate that you add, you lose degrees of freedom and you lose statistical power. So you frequently can't include all the many other things that might be important, like how much does a person drink? Do they also smoke cigarettes? What's their age? What's their income? What's their sex? So many of the studies that are relatively small in size may also have bias because they're not including the appropriate covariates to incorporate those potential confounders. These are examples of some of the studies we've done recently to try to address this. We've done a number of studies in the Human Connectome Project data set. The Human Connectome Project, for people who aren't aware of it, is a large open science project that is investigating the many different interconnections within the brain, and in particular, the patterns of connectivity during active mentation. One of the nice things about the Human Connectome Project, in addition to its large sample size, it has more than 1,000 participants, is that it has a full neuropsychological battery. You can see the neuropsychological tests here on the left and the kinds of cognitive functions that they're measuring on the right. And it also, in this study, very carefully analyzes people's cannabis use. And so what we did was look basically at 4 different dimensions of cannabis involvement and how they related to neuropsychological functioning. So these are the results, and I'll run through them piece by piece. You can see again the neuropsychological battery in terms of the tests and the functions. And we looked at 4 indicators. We looked at age of first use, total lifetime cannabis use, whether a person ever met criteria for cannabis use disorder, and whether or not a person had recently used cannabis as measured by a positive urine drug screen on the day of testing. That's another feature that was nice about the Human Connectome Project data set. And what we found was that there were 3 domains of cognition that were significantly lower: fluid intelligence, nonverbal episodic memory, and processing speed. That's consistent with the broader literature. Although the effect sizes, the amount of variance accounted for was relatively small. What was really interesting was that these were specific to different features of cannabis use. So ever having cannabis use disorder was associated with fluid intelligence, whereas having THC in urine, a positive urine drug screen, was significantly associated with nonverbal episodic memory and processing speed. That's very consistent with the systematic review I showed you before, because that would be consistent with regular ongoing use. This study would not be able to evaluate acute use. We've done similar studies in other aspects of the Human Connectome Project data set, looking at what's going on actually in the brain when people were in the scanner. And so in this case, we looked at the brain activity associated with doing a visual NBAC task. Visual NBAC is a neuropsychological task in which you measure working memory by asking people to indicate if they recognize a picture that was presented either 1, 2, or other numbers back from the one that they're looking at. You basically ask them to keep the picture in mind and think back a certain number of in the sequence. And what we found in this large data set was a very clear neural signature for what the brain is doing when it's successfully executing that task. Some of the core operations are executed by the rostral middle frontal gyrus, here up to the central middle frontal gyrus. You can see this down here in a sagittal image. You can see supplemental motor area, which is responsible for the actual task performance. The salience is being captured by the insula. And what's important to note also is you can see decreases in activity as illustrated in blue in the ventromedial PFC or medial orbitofrontal cortex and posterior cingulate, two key nodes in the brain's default mode network. So basically what we see is task positive engagement in middle frontal gyrus, insula, and other regions. And then we see task negative activity in basically reductions in the default mode network. When we looked at how cannabis related to performance on this task, what we found was that there were no differences based on lifetime amount of cannabis consumed, no differences based on CUD status or age of first use. The only variable that was significantly associated with NBAC performance in the scanner was THC positive status. That is, had a person used cannabis recently? And what we found was that if you had, there was a significant reduction in performance. And in terms of where that lived in the brain, there was significantly lower activity in the middle frontal gyrus. This is the task positive region that you saw in the previous slide, and significantly greater activity in the ventromedial prefrontal cortex. That's in the deactivations that you saw in the previous slide, indicating that there seemed to be a failure to suppress the default mode network when the task was happening. And then a really nice piece of the puzzle that was illuminated was we did mediating analyses, finding that the recent cannabis use, the THC positive status, in relation to working memory accuracy, was essentially mediated by these two reductions, or I should say reductions in task positive activity and increases in task negative activity. So by reducing brain activity during the task in the regions that needed to be used, people were doing worse. And by presumably leading to greater mind wandering or intrusions by not suppressing the default mode network, people were performing less well. This is really consistent with some previous evidence looking at abstinence effects. Across our Human Connectome Project data analyses, we've seen that recent cannabis use, as measured by the urine drug screen, really shows the most robust associations. And this is a nice study from now quite a long time ago, showing that cognitive performance changes dramatically over the course of abstinence. So on the left-hand side of your page, you can see the nature of this design. Basically, individuals who were active cannabis users, former cannabis users, and healthy controls who didn't use any cannabis were compared in terms of cognition at baseline, day 1, day 7, and day 28 in a protocol in which the active cannabis users were monitored for abstinence during that period of time. And what you can see is that former cannabis users actually don't look different from control participants on any of the indicators at any time. So not using cannabis anymore was associated with not having any cognitive differences. The active cannabis users did show significant decrements on day 0, day 1, day 7 in general, but by day 28, those decrements had gone away. So basically, the discontinuation of cannabis use meant the restoration of cognitive functioning. And that was the case also on a much more extensive battery of tests that were given at 28 days, in which essentially the cannabis users and controls all looked identical following that 28-day abstinence period. So discontinuation leads to substantial restoration in function, it appears. And this has also come out in a recent study that meta-analyzed the relationships with cannabis effects on cognition in young people. This is actually a slide that Krista Lisdahl showed yesterday also, showing that although there are significant effects on cognition, once you adjust for the amount of abstinence required, this is the meta-analytic effect size overall, and this is for no abstinence, which is about a third of a standard deviation decrement. Same for studies that required fewer than 72 hours abstinence, but with 72 hours abstinence, the effect size actually overlaps with 0 and is substantially smaller, suggesting that, again, discontinuation leads to substantial increases in function. I'm going to show three more cannabis and cognition studies that also highlight another relationship with cognition that I think is particularly important. This is a study we did using data we collected here in Hamilton on healthy volunteers from the community. Again, we have a neuropsychological battery of tests. They measure different cognitive functions. And what we found was that in nearly 1,000 people, there were some associations between cannabis involvement, but they were restricted to a relatively small number of indicators, a measure of impulsive decision-making, and actually both subscales in terms of self-reported ADHD symptoms. The more objective neuropsychological tasks, like the tasks measuring working memory or inhibitory control, did not show significant associations in this large sample. And so again, once we incorporate all the other covariates like income, alcohol use, tobacco use, sex, and age, there seems to be a relatively modest association with cognitive performance. The betas in this study were what we would consider it sort of the high end of a small effect size of 1.18, 0.17. And these were exclusively associations with people's performance on the QDIT, the Cannabis Use Disorder Identification Test. When we looked at age of first use, and when we looked at age of first use in combination with QDIT score or current severity, there were no significant relationships. So age of first use did not show any impact on later adult cognitive performance. These were individuals who were on average about age 40. And so in this case, we see evidence for level of involvement, but not when a person started. We've done 2 studies on emerging adults, one in Canada and one in the US, using very similar batteries. And so you can see, again, on the left-hand side, the neurocognitive test and the associated cognitive function. And here again, what we see is that the associations tend to be with impulsive decision-making, overvaluing small immediate rewards relative to larger delayed rewards, or something called delayed discounting. And also, in this case, again, an association with ADHD symptoms. The relationships, once again, were specific to the QDIT, the Cannabis Use Disorder Identification Test, and we saw no association with age of first use. So when it came to overall IQ, inhibitory control, attention, verbal attention, working memory, none of those domains revealed associations with cannabis involvement after we included things like age, sex, income, education, alcohol, and smoking level also. These are our US results, our Canadian results. In the US, what we saw was remarkably similar. This is a cohort that was recruited in Memphis, Tennessee. We used the exact same battery. We did see a small association with working memory in this cohort, which was very interesting, but an identical profile of other associations in terms of impulsive decision-making, and also ADHD symptoms self-reported in terms of hyperactivity. And this, I think, really is concordant with some of the results that Krista Lisdahl showed yesterday on the association between cannabis use and ADHD and how complicated that relationship is. The reality is it may be that cannabis is leading to at least self-reported ADHD symptoms to the extent that people may feel like they are experiencing some cognitive deficits, or it may indeed be causative of the clinical syndrome of ADHD. It's equally possible that ADHD, which is inherently a diagnosis of childhood, that has to be given first in childhood, may lead people to use cannabis because it may have what they consider attractive sedating properties and may reduce some of that motor hyperactivity, although unfortunately, may also have with it some of the negative cognitive consequences. And then the other possibility is that there's a third variable, some sort of shared underlying vulnerability that leads to the expression of both cannabis use and ADHD, but the two are not necessarily related to each other so much as a function of this third variable. So this is a very active area of current inquiry. All right, let's leave the brain behind and move to cannabis and lung health. And I'm just going to be relatively high level in this section. When it comes to cannabis and lung health, the fundamental thing, in my opinion, to remember is that any smoke is bad for the lung. Tobacco smoke is bad for the lung. Cannabis smoke is bad for the lung. Smoke from a house fire is bad for the lung. Smoke from an occupational setting is bad for the lung. And so the question becomes, how bad is it for the lung? And how much is it specifically attributable to cannabis smoke as opposed to other kinds of smoke exposure, especially combustible tobacco smoke? So what do we know now? Well, the overall evidence suggests that specific to cannabis, there's evidence that cannabis is associated with chronic bronchitis and cough. There's also evidence consistently that cannabis is associated with deficits in the macrophages in the lung that are responsible for protecting the lung, what are called alveolar macrophages. And these cells essentially produce cytokines and serve as a first line of defense in the lung. And cannabis smoke has been shown to unfortunately lead to deficits in these cells. It's also the case that individuals who are immune compromised may be differentially susceptible to lung illness by virtue of opportunistic infections, or especially in settings where cannabis is not legal, contraband cannabis can be contaminated with Aspergillus mold. And individuals who have compromised immune systems may have particularly adverse reactions to Aspergillus. The good news is that there is not evidence linking cannabis specifically to lung cancer, and the associations with other major forms of lung disease like chronic obstructive pulmonary disease, COPD, are quite inconsistent at this point. Most people do not smoke cannabis the way tobacco users smoke tobacco, and so the level of overall exposure is considerably lower, and it may very well be that the lung risks are restricted to a much shorter list. One thing we don't know about is the lung effects of vaping, and vaping is an increasingly common and preferred way of consuming cannabis. It is, inhaling a vapor appears to be, from a lung standpoint, safer than inhaling a smoke, although inhaling a smoke is a very, that's basically a very low bar because inhaling smoke is such a harmful thing for the lung. At this point, we do know that contaminated vaping products can have terrible toxic consequences on the lung, but in terms of safe, quality-controlled vaping products and lung health, we really don't have a very good sense for what the lung risks are. And presuming that there are benefits relative to smoke inhalation, we don't know what the relative benefits are. So that's another area of very high priority for investigation. What about cannabis hyperemesis syndrome? So moving to the GI system, cannabis hyperemesis syndrome is a syndrome that comprises a set of GI symptoms: loss of appetite, pain, and a very strong sense of nausea with repeated vomiting for days at a time, that is often only relieved by taking very hot baths or showers. This is obviously quite an unusual syndrome. It was first documented in 2004 and was extremely rare, although appears to be getting much more common. The prevalence has not been estimated for the general population, although the number of reports in the emergency department, in emergency departments, are remarkably high. In fact, the Society for Academic Emergency Medicine is undertaking a systematic review to inform guidelines for managing CHS in the emergency department. Among frequent users, and that is typically defined as 20 or more days a month, or approximately daily users, some of the estimates suggest that CHS may be present in up to as many as a third of individuals. So with the increase in THC levels and the overall consumption of the psychoactive ingredient, it appears that CHS is becoming more common also. At this point, there are no well-established treatments. What has been shown to ultimately lead to the reduction in symptoms is terminating cannabis use, but the acute treatment tends to use antipsychotics or topical capsaicin, because traditional antiemetic or anti-nausea medications are not effective for managing cannabis hyperemesis syndrome. So in the last section of this talk, I want to kind of highlight one of the critical areas around the intersection of these many potential harms with medical cannabis use. And to reiterate, there are many people using cannabis for medical purposes. This is the buildup over 4 years prior to legalization, going from under 8,000 authorized users in Canada to over 340,000. We now know that the estimates are probably grossly undercounting, and that there are more than 1 million medical cannabis users. And this has a lot of relevance for the harms that could be experienced by these individuals. One of the biggest questions is, could medical cannabis lead to cannabis use disorder among these individuals, much like the unfortunate contemporary opioid epidemic? And a recent study really speaks to this in a much more direct way than we have had before. There have been typically reports that have had cannabis use disorder as a secondary outcome and rarely reported. In this case, a recent study came out from Massachusetts General Hospital that actually randomized individuals to getting a medical cannabis card or being in a waitlist control, and then looked at the effects of accessing medical cannabis on pain, insomnia, and mood disorders, and also simultaneously looked at cannabis use disorder development within the individuals who gained access to the medical cannabis card. And what they found was quite striking. 17% of people who got the card right away at the end of the trial met criteria for cannabis use disorder. That's close to 1 in 5. That's not a small number. And certainly in some of our observational data sets, we've seen rates that are similar or even higher in some cases. The adjusted odds ratio here was nearly 3, meaning that people who were in the immediate card group were nearly 3 times more likely to meet criteria for cannabis use disorder. And they noticed this most substantially within patients who were seeking out medical cannabis for anxiety or depression. So certainly it seems like we need to be aware of the fact that medical cannabis can indeed potentially lead to cannabis use disorder. The other reality is that there are important patterns of overlapping motives for use. And these are data I showed during the first foundation session for those of you who saw them. This is a cohort we recruited locally, and looking at about 700 cannabis users. To start with, we found that about 40% reported any use for medical purposes, and that basically 80% of those who reported any use for medical purposes reported not just using for medical purposes, but used using for what we call dual motives, using both for medical and recreational purposes, both to alleviate a condition and also to enjoy the psychoactive effects. And this is really important because these individuals look quite different from each other. So when we compare the dual motives users to medical users only, and there's a lot of data here, I'll walk through it column by column. These are some of the different characteristics of the different individuals. These are all the cannabis users, the recreational users, the medical users, then subdivided into the medical only and the dual motives users. And what we found was that when we looked at how often people use cannabis, the medical users used more frequently, but the dual motives users used the most frequently of all. They were the most high volume, high frequency consumers, I should say. When we looked at the cannabis products that they use, the medical only users tended to use products like topicals or liquids, tinctures, whereas the dual motives users tended to use the recreational products like dried flower cannabis. The medical only participants typically used low THC products with high CBD, what we would consider low risk products. And when we looked at the level of problems using, again, the cannabis use disorder identification test, the medical users had higher QDIT scores, but the dual motives users had the highest QDIT scores of all, suggesting that there were substantive levels of cannabis related or compulsive cannabis use or cannabis use disorder symptomatology within that group. We also saw big differences between why people were using cannabis. So if we look at the dual motives users, the med plus rec versus the medical only, what we found was that those individuals were much more likely to say that they were using for mental health reasons. They were using for anxiety, for depression, for sleep problems, and for PTSD. When we look at the medical only, we found that that group was significantly more likely to report using medical cannabis for arthritis, muscle spasms, and chronic non-cancer pain. So what we see within the medical cannabis, within the broad community of individuals using medical cannabis, there are very different patterns of use. One group that very much sort of overlaps with recreational use and seems to primarily be using for mental health purposes, and another group that looks more like what we would think a traditional medical cannabis population would look like in terms of using only for medical purposes and primarily using for pain or muscle spasms. All right, so some final conclusions. The critical consideration here is what I hope is kind of a through line to all the work we do at the DeGroote Center for Medicinal Cannabis Research, which is to focus on the data and the evidence. That is, how do we really balance the risks and harms and think about the overall aggregated harm profile? And this is an example of some data that did this in a very formal way. I hope you're doing it in a kind of mental way over the course of this talk in terms of identifying in your own mind how risky cannabis is. In this case, this is a study asking addiction professionals to review the harms of different drugs, either to the individual or to other people, and to then numerically categorize how significant those harms are. And what you can see is an overall harm score on the y-axis and all the different drugs that were considered on the x-axis. This came from a study in the UK, hence some of the spellings. And what you can see is that overall, cannabis falls basically in the middle. It has some harms to the user. It has some harms to others. It is by no means as significant in terms of the associated harms as cocaine or heroin. Indeed, what's interesting is that actually alcohol is rated as the most harmful, both because it has substantive harms to the individual in terms of both acute harms, for example, car crashes, assaults, accidents, but also chronic harms like cancer risk, liver disease risk, and then major other harms to others, again, via impairment and unfortunately associations with outcomes like domestic violence. So in the grand scheme of things, we have to take all these data and put them into our own mental algorithm to think about how severe the risks and harms are overall, and how severe they are in the context of both general cannabis users and medical cannabis patients. And there's no simple black and white way to say cannabis is either good or bad. As you can see from the data I presented today, in some cases, there's clear evidence of risk and harm. In other areas, those associations tend to be quite small and limited to specific patterns of use, like daily use. And so these have to be ultimately brought together into this yin and yang of thinking hard about to what extent for a given condition or for general use may the benefits ultimately outweigh the harms, or is the alternative the case? And at this point, I will stop, and I hope we have time for a few questions. Thank you very much for your time.
Thank you very much, James, for that wonderful summary of harms. There are a few questions. If you do have more questions, please feel free to type them into the Q&A. And if we don't get through them all live, then Jim Traps can answer them individually. First one from Margot. Looking at treatment for cannabis use disorder, would activities like exercise and meditation help to boost the endocannabinoid system? I'm wondering if we know of ways to help with brain recovery from CUD.
Excellent question. The best supported treatments for cannabis use disorder at this point are largely psychological interventions like motivational interviewing and cognitive behavioral therapy. There are no approved medications, but the activities that you identified are exactly the sorts of things that we would often recommend in the context of, for example, either motivational interviewing or cognitive behavioral therapy as alternative activities for enjoyment and reinforcement. And both are, certainly exercise is implicated in endocannabinoid release and the release of other what are typically perceived as pleasurable neurotransmitters. So both of those activities would be, as a clinical psychologist, on my list of things to prescribe, so to speak, for individuals seeking treatment for cannabis use disorder.
A few questions from Jacqueline. First, have you looked at cognition in medical users? I have patients that do better in school with cannabis, which may be because they are less distracted by their symptoms. In at least one patient, the patient attributes it to counteracting the cognitive effects of gabapentin.
I think that's well, number one, I'm not aware of any studies that have looked systematically at cognitive deficits using neuropsychological tests in medical cannabis patients. So I think that it's a really important question because medical cannabis patients are typically using more frequently, often on a daily basis, for symptom management. And so the likelihood of impact is higher, I would think, but we don't really actually know what the data say. We do know that in self-report measures, some individuals do report having cognitive decrements as side effects. That is an established side effect profile. Now, I think that to the question of could there be improved performance, there could be. And certainly one hears from individuals that anecdotally that it might be helpful. I have a lot of trouble personally squaring the evidence of, albeit moderate associations with negative cognitive effects, with there being benefits. But it's always possible. It's just that there isn't evidence. And it is the case that it may be that there could be other side effects from other drugs that cannabis could ameliorate. It's conceivable, but I think that that's also a very tricky thing because you now have a number of different medications and you're using one to try to offset the downsides of another. And there are in turn further risks from polypharmacy or multiple drugs being used at the same time. So are those conceivable outcomes? They are. Is there evidence that would lead me to think that they're likely not very strong evidence, I would say.
Also from Jacqueline, what about the effect of using a dried herb vaporizer, as the vapor does not have pyrolytics?
Yes. So that has not been systematically evaluated, but certainly if I were to recommend an inhaled route of administration, it would be by vaporizing, because by all measures, the expected lung harms would be lower. There's a very large clinical trial that is being planned to be undertaken in the United Kingdom to look at cannabis for pain with 10,000 patients, and their intended product is a cannabis vaporizer, in part because people report benefits when using inhaled cannabis, and that's a way to avoid the known downsides of inhaling combusted plant material. It's sort of as simple as that. Is there an extensive evidence base? No, but certainly logic would lead me there.
We'll take one more question from Tom. I'm interested in the fact that CB1 receptors seem to recover, at least in numbers, over time in regular chronic users. Assuming this also applies to users with CUD, how do we explain withdrawal symptoms if there are normal numbers of CB1 receptors? Are they not as functional, or could there be deficits in brain levels of anandamide and its congeners in chronic cannabis users?
That's a great question, and I think it comes down to the time course. I think that if you think about those data over 28 days, we did see a gradient of increase in CB1 receptors, and that's basically the brain recalibrating after the discontinuation of exposure to THC regularly. The withdrawal symptoms would more or less map onto that time course, insofar as the brain is recalibrating, it feels very uncomfortable because you suddenly have a deficit of that underlying receptor. It's very similar to alcohol withdrawal or opioid withdrawal. Both of those drugs have withdrawal syndromes that are essentially a function of downregulation or upregulation. In the case of alcohol, it's downregulation of GABA receptors and upregulation of glutamate receptors. In the case of opioids, it's a downregulation of opioid receptors. In both cases, there is neuroplasticity that leads to a restoration of the system after discontinuation. But during the time that that's happening, it's very, very uncomfortable. And it's not necessarily, 28 days is not a magic time window. It can often take much longer than that. We frequently hear people describe what are called persistent or chronic withdrawal syndromes in alcohol and opioid use disorder. And that's likely for cannabis also. So it's a long-term process for the brain to return to its pre-existing state.
You want to do the last question live, or do you want
Sure.
to answer? Okay, so the
Last
last question from Jacqueline. For the study looking at getting a medical card, did they have a cannabis use disorder prior to getting the card? Some people may be getting a card in the States where recreation is illegal.
That's a great question. In that study, they were specifically recruiting people who did not have cannabis use disorder and were not actively using cannabis to participate in the trial. So this would be, that's why I refer to it as the incidence of cannabis use disorder, because these were new cases in which people met criteria after at the end of the trial. Excellent question.